So, hopefully, again, I gave you a lot of reasons that you should be kind of scared that you've missed strokes before, as I am. I'm sure it's happened because it's what happens. But other than a good identification, what do you do if you suspect it? So you roll up on again an elderly person, and they seem to have a sudden onset neurological symptom, which is again what you are really looking for. What might you do at that point? Well, number one, I sort of mentioned it a second ago, but you got to identify these things. So it is real helpful to do some kind of stroke screen. That can be, and usually in a lot of protocols, what you're going to find is the Cincinnati Prehospital Stroke Scale, or the FAST, FAST, face, arm, speech test. You don't have to use the Cincinnati one. I'm from Cincinnati, so like sounds good to me. But the Cincinnati one, the nice thing about Cincinnati one is it's relatively simple. Everybody probably remembers this, and you don't have to be a paramedic to do it. You don't have to be a critical care person to do it. This is real simple. Let's just do a couple of things. Number one, ask them to smile. Is their face symmetric? And the places that you might be looking. So, for instance, your nasolabial folds here. Well, this is hard to talk and do. Your nasolabial folds right here. A lot of times you'll find subtle little things right there. The patient may be able to get the sides of their face up like that, and they may be able to smile like that, but you may notice that one side, you just don't get as prominent a fold there. And that is facial asymmetry. That's a subtle finding, but it's definitely there, and that's sometimes all you're going to get. So you look at their face and see if it looks symmetric when they smile. And if one side doesn't move as well, it can move, but if it doesn't move as well, that's a positive. Then you ask them to close their eyes and put their hands out in front of them and hold them there. And if they move, together, then it's a little bit less. Maybe they're just like tired or something like that. But if they move differently, if one arm drifts down even just a little bit, it doesn't have to hit the floor or anything like that. If it's just a little bit, one compared to the other, that's concerning. And then you ask them to talk. And the one that we usually say is, you can't teach an old dog new tricks, because that makes your face move around and you know what that should sound like. If they slur their words, or if they say the wrong words, or if they can't talk, then that's a positive. And by the way, what does it take to be positive on the Cincinnati Stroke Scale? This is a yes or no. This is a binary at the end. If the patient cannot do all these things essentially exactly right, that is a positive stroke scale. And this is a screen. This isn't a definite, oh yeah, he's got a stroke because he's got a little slurring of his speech. If you drink alcohol, you can get some slurring of your speech. But that would be a positive on the FAST exam. And again, the idea here is to identify as many as possible early on, and suggest that it might be there, but not to say this person definitely needs thrombolytics or something like that. The whole idea is to catch as many as possible while sacrificing the true accuracy of it. So the FAST, and it is pretty good. It catches something like 85% of strokes or something like that, if I remember correctly, as a sensitivity. Not too awful bad as far as that goes. The nice thing, you can use the LA scale, you can use whichever scale you want, or screening tool, whichever one you want. The nice thing about the Cincinnati one is that it is easy to remember. So pretty much any of us can remember with relative certainty, looking for facial droop, have your arms in front of you, say, can't teach an old dog new tricks. And if you can't do all those things exactly right, that's a positive, and you need to kind of go on from there. Worth mentioning too, again, what might that miss? What's that like 15-20% of people that might not identify? Well, if you got a stroke in a weird spot, like in your pons or in your brainstem, someplace, kind of down here or posteriorly, you may not find that because it's not checking for hand numbness. It's really not evaluating for dizziness. It might be a little bit of lost coordination or something like that, but not vertigo, not trouble swallowing, maybe not even double vision or trouble balancing. So this is not the end all be all. If the person has a sudden onset change with a neurological symptom, you still got to be thinking it, but it may not get picked up by one of those stroke screens. There we go. Okay. As a matter of fact, this is a busy slide, but these are the stroke presentations that get missed. And what do they look like? Well, it is, there we go. Look over here. These are symptoms that are more likely to be missed as a presentation of stroke. And what could it be? Well, difficulty walking, falls. How many old people have difficulty walking? All of them. That's, how many people in this nursing home have difficulty moving around? Every one of them. That's why they're in the nursing home. They have falls. Vision changes, you may not pick up on that. Syncope won't be picked up on those most likely unless they have a motor deficit afterwards. Seizures and dizziness, nausea, vomiting, headache, that kind of stuff. That's all out there. And even you probably are going to pick up like neglect, but it may look weird to you. So you have to do the scale. You have to have the presence of mind to do the scale to start off with. Long story short, again, you got to be careful. And the question should be, is this an acute neurological change? Yes, you should do some kind of stroke screen on anybody that looks at you funny, just to make sure. And sometimes you'll be surprised what you actually find out. You would think they wouldn't actually have it, but they do, in fact. So is there an acute neurological change? And if there is, then you got to watch out, because this could be a stroke. Now, once you think there could be a stroke, now we can move into a little bit of the other stuff you got to do. And I call this out specifically. Yes, ABCs are super important. Of course, we're going to watch them. We're not going to make them hyperoxic. We're not going to put them on oxygen if their pulse ox is greater than 93, 94, depending on what your local protocol is. These folks don't necessarily need oxygen. They don't necessarily need blood pressure control. We'll get into it a little bit here. But the thing that you got to remember is that once you identify the stroke stuff, get a finger stick. And this also goes with anybody that is altered or, again, looks at you cross-eyed. If they're in the least bit wacky, then you should check a finger stick. The same way that you should probably do a stroke scale in the same vein. We have had, many people that get intubated because of hypoglycemia, people that get long seizure treatments because of hypoglycemia, folks that have gone into an emergency department and gotten thrombolytics as a consequence of being hypoglycemic. These things all happen. So you got to check a blood sugar, and more, surprising number of times you'll actually find that they are hypoglycemic. So this is not just like a thing to do. There are real treatment implications for this. There are many folks that have taken long helicopter rides because nobody checked a finger stick. And then you give them some glucose at the tertiary care facility 100 miles from their home, and all of a sudden they wake up and the stroke is no longer in existence. So check a finger stick. After you check the finger stick, you got to find out when this guy was last well. And again, why do I say that? Because everything that we're going to do hinges on when this guy was last seen normally. Let me give you a graphical representation of why that's important. Say that this cat is found at 8 o'clock with some right-sided facial droop, right arm weakness, right leg weakness. Found at 8 o'clock when his family returns home from the movies or something like that. The treatment window to get a lot of, especially like the thrombolytics, TPA, the stuff that we really are like moving to try to do, about 4.5 hours, kind of at the outset. Usually 3, you could extend it out to about 4.5, depending on what's going on. So you've got that period of time. And if he's found, at 8 o'clock, if you said, symptoms what was the onset of symptoms? 8 o'clock. Okay, I've got till 12:30 to get this stuff in place. And so I've got a little bit more time. Maybe somebody in here throws in like, oh man, we're not sure at 9 o'clock if he's having a stroke. It takes us about 45 minutes to get all the stuff together and talk to the neuro guys. And they say, well, okay, he's pretty early in it. We've still got a couple of hours. Let's see if we can let's see if we can get a stat MRI, which is going to take an hour to sometimes an hour and a half, depending on what all has to happen. And we'll still have a little bit of time left over to maybe give this guy TPA if there's any question about it. That's cool. Unless the person didn't have the onset of symptoms exactly, at 8 o'clock when you found him. What you have to go by the last known normal for is because you have to assume that if he was last seen at 5 o'clock, in order to do the rest of the stuff safely, you have to assume that his symptoms started at 5:01. The minute somebody took their eyes off him, you have to assume for the sake of safety that it started then. And so instead of having 4 hours from the time that he is found, you may have an hour and a half at best. Or, if you really miscalculated and he actually wasn't seen since 1 o'clock in the afternoon, the time for like the TPA window may be completely passed. And if you give him thrombolytics at 11 o'clock at night, you definitely increase the chance that he's going to bleed as a result of it and potentially die. So the last known well time, the last time somebody saw him normally is the time when you have to go with. Sometimes that can be like, I was sitting in a chair and I felt dizzy at 9:30 in the morning. Okay, that works. That's kind of the last known well because the guy can provide it. But most of the time, the patient can't really provide that history very well. You have to know when the last time somebody reliable saw this patient, confirm that he had a completely normal or baseline neuro exam for him. I cannot stress that enough. And if you don't get it in the field, a lot of times it doesn't happen. Trying to track down these people, and it seems like it should be simple. Oh yeah, everybody just call somebody. Driver's licenses get lost, phone numbers get changed, people don't answer their phone. You have to find out in the field, and you have to make that a reliable report. When was the last known normal time this patient was seen? Last time this patient was seen normal. Absolutely critical. All right. I mentioned a little bit, we're going to do his ABCs with normoxia. We're not going to let these people aspirate if at all possible. Most of these folks with strokes, even big strokes, usually don't need to get intubated kind of right away. So if you are a critical care provider or a flight crew or something like that, bear in mind that a lot of times these folks are looking a little iffy, but don't actually need to get intubated, at least acutely. Sometimes they do, absolutely, sometimes they do. But a lot of times we can kind of get these people through, and if you can keep them awake and able to protect themselves, something like that, then it's a little bit better. These folks don't necessarily need oxygen. If their O2 sat is greater than 94, they don't need oxygen. And there's some data that suggests that hyperoxia makes the infarct size a bit worse. So don't put them on oxygen if they don't need it. But we do overall want them to think and want their brain to think that nothing is going on, that this is just a normal status, because that's what the brain likes. Now, there's, of course, that area that's ischemic, but for the most part, we want the brain to be thinking and the body to be thinking otherwise. Oh yeah, this is just a normal day. So normoxia, normocarbia as much as possible. They're going to be a little hypertensive, but not severely hypertensive and not hypotensive. That kind of stuff is what we want the rest of the body to think in the setting of a stroke. And then we have to, after, boy, that's not 3 at all. It's like 5 at this point. I can't remember. But once we have done the initial screen and we think this is a positive, this is positive on the Cincinnati Stroke Scale, or so they're positive on the FAST exam, and we've done a finger stick and shown that it's not hypoglycemia, and we have found out the last known well time, and we've made sure that he is, oxygenating well and not about to like choke on his own vomit or something like that. We then need to kind of size things up. And when I say size things up, I mean, is this a large stroke? Is this a big blood vessel that is clotted off? Is this a large vessel occlusion? Get myself out of here for a second. You can see, again, not a radiologist, not a stroke doctor per se, just an ER doctor. But you notice out here, we'll call this more or less normal. You notice all this spiderwebby type stuff on this angiogram. You notice that back here, you don't really see all that. And this big blood vessel here that we note here goes up and all the way out here. We don't really see that here. So this is a large vessel that has become occluded, i.e. a large vessel occlusion, or an LVO. These are interesting things because this is the big stroke. This is the guy with the NIH stroke scale of 16 or 20 or something like that. The guy that is paralyzed on half of his body. They can't talk, they can't walk. This is the big stroke that you're looking for. Usually they're not super subtle because it takes up so much territory in the brain that you almost can't help but see the deficit with it. And it's usually of note too, there is like this little area right at the tip of where the occlusion happens that is the worst of it, but all the territory downstream of it gets a little decrease in blood flow as well. Now, sometimes you got lots of good blood vessels that run from other parts of the brain and kind of loop around there. But usually there's at least a little core area that gets affected mostly, and then there's this little watershed area that is sort of plus minus on whether or not it recovers, which is a big deal and kind of drives the rest of this stuff here. One more time with feeling, this is a big area, so the territory that may be supplied by your middle cerebral artery may include all this here, like basically half of your brain, your face. This is motor over here. Your face, your arm, down through your leg. If this all gets occluded, that area may die if it's not rapidly helped. And so that's why these LVOs are like the big ones, because they affect your face, your arm, your leg, kind of the whole half of your body, or an entire, your ability to speak entirely or something like that. So we need to know about these things, and it'll kind of drive treatment. We'll get into treatment in just a second. I'm talking too much about it. When we start talking about how to quantify these things and determine if it is a large vessel occlusion, you should do some sort of large vessel occlusion screen. So we have done the Cincinnati or pre-hospital scale, or the basic screening exam, the face, the speech, and the arms. Now we want to do something that is a little bit more in depth, that will identify the guys that have these big clots. The CSTAT exam, the Cincinnati Stroke Triage Assessment Tool, which, although it's listed as triage, is a little bit more of a fine point. It's still basically a screen, but the idea here is not to identify all strokes. It's to specifically pull out the large vessel occlusion. And how might you do that? Well, it's just slightly more complicated. Now you have the person, look at my finger, watch it. Is their gaze impaired in one direction? One eye goes this way, or they can't look to the left, or one eye seems to move and the other doesn't, something like that. If that's the case, if their gaze is impaired in one direction, that gives them 2 points. And honestly, if their eyes don't move in either direction, I would call that bad too. Then you check their level of consciousness. You ask them to do 2 commands, and you ask their age and their month. Not a particularly hard test to do. If they can't get all those things, if they can't say both their age, the month, close their eyes, and open and close their hands, if they don't do all that right, then they get scored as a point, a positive. So you get 2 points if your eyes don't move. You get 1 point if you can't do one of these tasks, and it's only 1 point. And then arm weakness, you put their arms up in front of them, and if one arm drifts down toward the bed, or in this case, if they both drift down toward the bed, if they can't hold up both their arms for 10 seconds, then they get scored as another point. 2 points basically gives you a positive. So how could you interpret that? If they can't answer your questions, follow your commands, and their arms drift down, then that's a positive CSTAT exam, which indicates there's a good chance this is a large vessel occlusion. If their eyes don't move, that's 2 points. And that says that's positive. You really don't necessarily have to do anything else, because the question is only, is it a positive test or a negative test? If they get 2 points, then the concern is that they have a large vessel occlusion. You need to treat them that way. They could have 4 points, and you would say, okay, probably large vessel occlusion, but you don't treat them any differently as if they have a 2. That's sort of confusing. I'm not saying it real well, but basically, if you can't do all the stuff on this test, then there's at least a decent likelihood that they have a large vessel occlusion. If you don't like the way that that's worded, you can find the scale and do it a little bit differently. This is just a little different way of phrasing it. They incorrectly answer age or month, or they don't follow one command, that kind of stuff. But same scale. I have a little bit of trouble remembering these sometimes, so I usually write it down or look it up on my phone, make sure that I'm doing things right. But basically, if they can't do all these things, then you got to be concerned they could have a large vessel occlusion. Now, you don't necessarily have to use the CSTAT, but the CSTAT is nice because it's fairly simple. It's 3 points, and I don't trust myself to do it exactly right, but you could remember it if you wanted to. You could do something else. There are lots of large vessel occlusion stroke scales. This is the race scale, which we won't go through. And you notice it's quite a bit more complicated. There's a lot of other things in there. They mentioned like, whose arm is this, that kind of stuff. And these are all tests you can kind of do and that sort of thing. But it looks at aphasia. It looks at head and gaze deviation. There's leg motor function, there's arm motor function. And then you score them based on that as well. And you basically anything is potentially bad, but there's the race scale, there's a bunch of other stuff in here. The reason that folks like the Cincinnati one specifically is because they're pretty simple, right? It's three tests, or three things on each one, and fairly easy to interpret. You don't need a whole lot of like training in it. You could basically just hand somebody a card and say, hey, go have this guy, EMT student, go have this guy do these things. And that person should be able to interpret it. That's the nice thing about the Cincinnati ones. A little more complex, a little harder to use as you get into the other ones. But if you like the race scale, do the race scale. Again, just same way as the other. If you like LA instead of Cincinnati, okay, do LA. doesn't matter that much. They're basically all kind of the same. It's whatever one is appropriate is whichever one you do correctly and then act on. So, right, when this started and how big it is, the two pieces of information, when was the last known well, and whether or not this is a large vessel occlusion, is important because it makes a big difference in what treatments the people get